Crohn's disease of anorectum. We are going to discuss the Crohn's disease of anorectum. Now, in the Crohn's disease of anorectum, I told you that it is associated with development of multiple fistulas or perianal abscess, fissures which are not present in their 6 o'clock position. It can present in the lateral position also or anteriorly also. And I've told you that it anti-TNF therapy is used in if there is perianal Crohn's which is not responding to the routine medication, then we use the anti-TNF therapies. Infliximab is used. Okay, and we generally don't go very aggressive for fistulectomy. We generally prefer fistulotomy. Initially we try to give antibiotics and along with that this anti-inflammatory agents. If it is responding, then it is very good. If not responding, we'll control the local sepsis with IND of the abscesses or a fistulotomy or a sit-on placement. Fistulectomy is generally not performed. Okay, so now we are going to discuss Crohn's disease of the anorectum. Now, it is seen in up to 20 to 25% patients of Crohn's disease. Okay. Now, most common presentation is ulceration. Others are fistula, stricture, fissure, abscess. Okay. This fistula is cyanotic, chronic, indurated, generally painless. Okay. So it is associated with fistula, stricture, fissure or abscesses. So what is the clinical feature? Generally there is either pain due to the fissure or there is pus discharge due to abscess or fever or anal swelling. Okay, so the clinical features are there is pain, swelling, bleeding, anal incontinence, fever or edematous purplish tags. These edematous purplish tags are characteristic of Crohn's disease. Okay. There can be edematous purplish tags. Now, how we are going to manage? What is the management? As I have already told you, most patients will be managed conservatively because if we are going too aggressive for a surgical management, there is risk to the continence. There is a threat to the continence of the patient and there is increased chances of developing incontinence. So we should try and first manage the Crohn's disease of anorectum conservatively with the medical management. So most patients are managed conservatively. Okay. Patients are managed conservatively. Surgery is done if there is undrained or poorly drained abscess is there. In case if there is abscess or if there is fistula associated with abscess and which is not draining properly, then only we'll go for surgery. Okay. Now, few points regarding fissure in the Crohn's disease. Fissure I have already told you, normally the fissure is occurring at 6 o'clock position, but in Crohn's disease the fissure can occur in other positions or lateral positions also. Okay, so the fissure is multiple. Generally it occurs single, here it is multiple, located off midline. Okay, we should avoid fissurectomy or lateral sphincterotomy. Okay, we should avoid surgery, try and manage it with conservative or medical management. Now, the next thing is role of infliximab. What is the role of infliximab? Infliximab is having role in, or a good role in, fistulizing Crohn's disease. And what is the fistula closure rate? The fistula closure rate here is 25 to 67%. It is having a good fistula closure rate, 25 to 67%. Okay. It is having a good fistula closure rate of 25 to 67%. Okay. Now, we are going to manage this fistulizing or these Crohn's disease of the anorectum in a staged approach. Okay. So, what is the staged approach? What is the staged approach for this Crohn's disease of the anorectum? Now, in the first step, initially we should control local sepsis. Okay, first step is control local sepsis. If there is any undrained abscess, we should drain that abscess. Okay, so there should be IND of the abscess. Along with that, we will give antibiotics. Which antibiotics? I have already discussed. The antibiotics are ciprofloxacin and metronidazole. Okay. If there is a chronic fistula, we should drain it with a draining Ceton. The non-cutting Ceton. Okay. So we have controlled the abscess and the fistula with a draining Ceton, and we have given antibiotics. After that, we will give infliximab. We will give infliximab only after control of local sepsis. Okay, only after control of local sepsis. What is the fistula closure rate? 25 to 67%. So around 40-50% of fistulas will heal. Now, next is after 2 to 3 infusions of infliximab, we will remove the Cetons for fistula closure. If fistula heals, then it is very good. If fistula does not heal, then we should go for surgery of the fistula. And the preferred treatment should be a fistulotomy rather than going for a fistulectomy. Okay. So that is about